Thank you so much for having me here with you today. I'm very grateful and excited about this convening because something like this wouldn't have happened 10 years ago. And so all of us coming together and seeing all of your smiling faces and the expertise that you bring to the table is really encouraging. I know for myself, and I'm sure for all of you, and just particularly love seeing all of my public health team here with us today to talk about the great work they're doing, and also the opportunity to learn from all of you about the work that you're doing in your respective organizations. Also, just want to give a quick thank you to Dr. Kumar and Dr. Liang. You guys have been really captaining this ship, and because of you, we're here today, and I just am very grateful to both of you. So thank you for all of the work that you've done. I think, in Riverside County, we're so very fortunate because we are really forward thinking. And I think that a lot of outsiders wouldn't think that when they think of Riverside County, because we do have a conservative community, but we have lots of people that are working in this community to improve the lives of our residents and visitors every single day. And just speaking for RUHS, it is so incredible to be part of a system where we're really looking at upstream prevention through our public health department and our community health centers, but also the behavioral health aspects and then the medical center. So really being able to cover that entire spectrum of care, and then be able to partner with all of you that are on this call and all of the people that are out in the community that weren't able to make it today. So I just think that we have such a unique, exciting opportunity in Riverside County, and I see this convening today as kind of a further kickoff to a lot of that work that will be happening as we go forward. Public health is really an organization that is rooted in equity, and we like to say that equity is at our core and has been for a long, long time, as far as I can remember. In fact, I'm going to age myself just a little bit, and probably a few others on this call, when I talk about the fact that 15, maybe 12 to 15 years ago, we started working on a program to bring training to all of our public health employees around, it wasn't called DEI at the time, but around raising issues around racism and economic disproportionalities and all of those things. And since then, public health has been on a journey to really strengthen the training, the understanding of our workforce, and then extend our arms to the community and to all of our partners within and outside the county so that we can all be on this journey together. You heard one of our earlier speakers talk about the Healthy Places Index. And so I'm sure many of you are familiar with that, particularly as we've gone through COVID and it has been highlighted at many different levels. But just to give you an idea, in Riverside County, our Healthy Places Index score, which is an overall measure of health, it looks at 8 different policy areas and 26 different indicators. And our HPI score hovers around the low 30s. And just by way of comparison, in San Diego County, they're in the 60s, LA is in the 50s, and Orange County is in the 70s. So when we look at our surrounding counties, they have much better measures of health than we do in Riverside County. So while that is a little bit daunting because it just shows how much work we have to do, it's also exciting because we all know that we can make huge changes in the lives of the communities that we serve by doing this work and the work that we're hearing about today from all of our partners. One of the other earlier presenters talked about the fact that data doesn't tell the whole story. And I just think that is so true. And I look at, we have our epidemiologists on the call today, and they do amazing jobs at pulling data and analyzing data and presenting data and helping us use data to guide our policy decisions, but it doesn't tell the whole story. So we have lots of programs in public health that are focused on communities, our Black Infant Health Program, our Family Nurse Partnership, our Women, Infants, and Children's Program. And we have learned a lot throughout our journey, through our equity journey. But we've also learned a lot during COVID. And I think that the important thing that I want to just highlight from our learnings from COVID is the fact that you have to have boots on the ground. And others have talked about the fact that we have to listen to community. And I think that that is so incredibly important. I've had the privilege of going out into the fields with Luz Gallegos and her team and watching Dr. Leung out there with the farm workers, speaking in Spanish to them and answering all of their questions and really putting their minds at ease. I've seen other community groups, whether it's community-based organizations, faith-based organizations that are in the community day in and day out. And those are really the partnerships and the work that make a difference. And all of that is done, yes, in conjunction with data, but data alone doesn't get it done. It's really this partnership that is going to have the largest impact. I think the biggest lesson that I saw when I was out in the community, and as I go out into the community periodically, which by the way is my very favorite thing to do. And I know Dr. Leung also is very encouraging to all of us to do that because he really enjoys it. But it allows us the opportunity to see firsthand what our community is experiencing. And we say a lot that we're partnering with them and we want to talk with them. But I think most important is that we listen to them, right? Because they have the stories to tell that should guide our work. And so listening to them is so, so important. I just want to mention just a quick example of kind of how listening to community helps build the picture and tells a story that we don't get from the data. So recently, Dr. Leung and I had the honor of going out into the North Shore community with our partners at the Desert Healthcare District. And just kind of toured around the community, looked at some different things that were lined up, and got to see a community health center and a park that were built. And so, just really incredible work that has been done in that community. But then we heard the story of it only serves half the community. And the reason for that is because half of the community lives on the other side of a main road, and they won't cross that main road because Border Patrol patrols along there. And so they're afraid of getting stopped by Border Control and then all of the things that could happen as a result of that. So here we have these beautiful things that we think are meeting the needs of the community. And without talking to the community, we wouldn't know that it's not meeting the needs of the whole community. And so, again, just want to reemphasize the fact that talking to and listening to the community and partnering with them is really going to advance the work that we're all doing. I also just want to mention just really quickly, certainly from public health, you have everybody on this call, everybody in the community has our commitment to partner. I know that's true for RUHS because this is a core value across our system. But I think the other thing that's really exciting is the commitment from our county chief executive officer and the board of supervisors. They are 100% behind this work. In fact, Jeff Van Wagenen, our CEO, talks about the Healthy Places Index and talks about equity when he's going out into the community, which that would have never happened even 3 years ago. And so I think that that is tremendous progress and another indication of the possibilities with the work that we can do. So just kind of wrapping it up, I just want to say I'm so encouraged by the partnerships that were presented today and that we're going to hear about. We're going to be hearing from a lot of great presenters in this hour and in our final hour today. None of us can do this work alone, but I know that by working together and partnering with all of us and listening to the community, we'll be able to move mountains. So thank you so much for allowing me to share a little bit of our perspective today. And I am really excited to introduce to you Salome Waga and Wendy Hetherington. They are leading and championing a lot of our health equity work. And so they are going to share with you some of that work today, and I will turn it over to them. Thank you so much.
Thank you, Kim. First of all, I'm going to talk, my name is Wendy Hetherington, and I'm going to talk to you about harm reduction and stigma reduction. I am the Chief of Epidemiology and Program Evaluation here in Riverside County Public Health. And I'm also the principal investigator for our Riverside Overdose Data to Action. So this is where we take different sources for overdose morbidity or mortality, partnering with our Riverside County Sheriff's Coroner's Office, our emergency management department and behavioral health department to really enhance our collection, analysis, and reporting of data. And I don't have to share with all of you that, numbers have been increasing in terms of overdose mortality. As of our most recent analysis, 2021 preliminary numbers for overdose deaths is 799, and that's an increase more than double since 2016, mostly due to fentanyl. But I do want to point out that since the end of 2020, we've been noticing the increase of the combination of methamphetamine with fentanyl has really driven a lot of our overdose deaths recently. And more concerning is that since the advent of this program, where we've been able to enhance our data collection, we've been noticing that there's been a more than double increase in overdose deaths for people experiencing homelessness. And that's concerning because that is a population that oftentimes doesn't have access to resources and other things they need. So harm reduction. Harm reduction is our strategies and ideas intended to reduce the negative consequences of associated with drug use. And what we mean by meeting people who use drugs where they're at is literally going to them and giving them what they need when they need it. And addressing the root cause of use is putting a focus on the whole person rather than their drug use. And it promotes non-judgmental and non-coercive services and resources. And it's my opinion that harm reduction is good practice, because we can't just tell people how dangerous something is without telling them how to make it less dangerous. And some harm reduction strategies may be a little bit more palatable for some people than others, but messages such as always carry naloxone, make sure your friends and families have naloxone, um, you know, don't use alone. There's never use alone hotlines that people could call if they are alone. And one thing that I think as physicians or healthcare providers can do is when because addiction can look like anybody and anywhere, and and people who have a substance use disorder have other health needs as well. And one of the primary ways we could do harm reduction too is making sure all the other healthcare needs are taken care of and addressed, and urging people to listen to their body. So eat and drink water and stay hydrated, and because overall health also impacts risk of overdose. Next slide. And you could just click through all of these because we're running out of time. But these are just evidence-based strategies for risk reduction or harm reduction. So access to naloxone, access to medication treatment for opioid use disorder, academic detailing, fentanyl test strips, the being knowledgeable about the 911 Good Samaritan laws, where uh, you could help people who are suffering from overdose without legal consequence to yourself. And of course, syringe service programs, or formerly called needle exchange programs. Next slide. So stigmas, people who suffer from opioid use disorder or substance use disorder or alcohol use disorder, there's been a lot of stigma associated with that population. And stigma creates a barrier and leads to decreases in self-esteem and increases in social isolation. And isolation is really a big driver of addiction. Um, Specifically, stigma from health professionals actually decreases empowerment and subsequent treatment outcomes for individuals with SUD. And addressing and stigma from the public results from reduced public and political support for the treatment and policies that would increase access to treatment. And this goes from using non-stigmatizing language, such as instead of using addict, you say person suffering from addiction, or for suffering, you're putting the the person first instead of of other aspects. Next slide. So peer support services promote social inclusion and increase self-esteem to counter self-stigma. And then again, this is what I mentioned earlier. So when talking to people with a substance use disorder, use person first language, which would focus on the person and not the illness. Next slide. And lastly, it's better to support harm reduction and destigmatization and not criminalize behaviors associated with addiction. I have tons of research, and I could share journal articles that show that when law enforcement is involved in overdose prevention, it's not as effective. And just for discussion, more discussions need to happen so we could all work together to address the overdose, the increase in overdose that's occurring not only in our community but throughout the United States as well. We just need to partner and work together to work on focusing on the underlying issues of why people become addicted in the first place. Next slide.
Thank you so much, Wendy, for that presentation, and thank you, Kim, for setting the stage. I wanted to really quick, Salome Waga, epidemiologist by training, but also the program director of health equity for the Department of Public Health here in Riverside County. I wanted to really quickly touch on and build on what Kim had mentioned, and also give kudos to Luz. She failed to mention that her organization was recently invited to the White House to receive an award for their amazing work that they do. So she left that minor detail out. So thank you, Luz, for your continued partnership. But really wanted to talk about the idea of the true leaders leading the space when it came to vaccine dissemination and throughout COVID. Next slide, please. So early in the pandemic, it was very evident that COVID and its burdens disproportionately impacted our communities of color, and not limited to those who were contracting the disease, but also the economic impacts that came with COVID. The idea of working from home, the ability to do so depending on the category and the job specifications, the idea of remote learning, and if families had that capacity to do so, the idea of social distancing, and if individuals were able to do that based on the living situations and working situations. And the list goes on, and you're very familiar with this. But all of the pre existing disparities that impacted overall health and health outcomes were now compounded with everything associated with COVID. So this became very evident really early on, and we saw that in the sense of increased case rates and death rates in our minority communities of color. So when it came to vaccine dissemination, we created a vaccine equity task force to kind of get ahead of the curve and really involve the idea that although we did have very strict parameters on, at the time, categories of age for vaccine dissemination and perhaps career pathways, but the idea that the community knows best what they need, and also what Luz was mentioning earlier, that our food source were our agricultural workers out in the majority out in the Eastern Coachella Valley. So really focusing on what this task force that was built in um, December of 2020, yes, would actually focus on how we would effectively and equitably disseminate vaccine based on the basic guidelines and parameters we're given, but what our community truly needs. So the initial steps and thoughts were just to increase vaccine uptake rates, simply to be able to protect our most vulnerable communities and partners, but also that we are experts, and again, epidemiologists by training. So we look at the data and the trends, and we think we know what the community needs and what they want. And I think that goes for all of us as professionals. This is what I do. This is my job, and that's what I'm serving to do. But really hearing from the community and the idea of power sharing and power building with the community. And unfortunately, COVID is what brought and elevated the need for that even more so than before. But getting everyone in the same space virtually to discuss what each community needs and what would be most impactful. Next slide, please. So we began with our Eastern Coachella Valley focusing on our food supplies and food sources, and really the essential workers that were keeping our community going. So we built strong partnerships with both East County and Western County, focusing on the needs of the community based on the partnerships we received. Of course, these partnerships were catered kind of two-way dialogue and conversation between what the community needs and then the information that we were able to provide. Really partnering with faith-based organizations, organizations or community-based organizations such as TODEC to get ideas of how to best serve the community, really looking at unique need communities and some of the organizations that represent those communities that know them best. Next slide, please. One of our main focuses, sure.
We're almost
Am I running out of time? Yeah.
Yes. Yes.
Sure. I'll run through, no worries. The idea that partnering with organizations such as TODEC who were in existence, they were familiar faces, familiar spaces, and they were able to convey factual information to our communities and really be able to educate them. So it was our work, their partnership, and really their spaces and their faces that brought all of this together. Next slide, please. And I know I'm running out of time, but really quickly, the very last map I want to show is the green areas are the areas in which we've made the most impact and lowest case rate, highest vaccine uptake rate since the beginning of the vaccine equity and vaccine dissemination. And this is probably the quickest return on investment we've seen in public health. In about 1 year and a couple months, we've gone from bright red to bright green. Is something that we're really proud of, and we hope to continue to build those partnerships, but want to really emphasize the idea of power sharing and power building and listening to our communities based on what their needs are. I made it, Dr. Liang. I'm done. Thank you all.
So next, we wanted to introduce Dr. Kathy Huang and Dr. Elmira Yang from our internal medicine department. They'll be talking about crossing the transgender care gap, as well as along with their internal medicine residency program. Thank you.
Thank you. Hi, good afternoon, everyone. Thank you for the opportunity to present today. My name is Elmira Yang, one of the endocrinologists here at RUHS. I'm co-presenting our project regarding transgender care with Dr. Kathy Huang. Next slide, please. So from previous studies, we have learned that various degrees of healthcare disparities exist among different groups, and some populations, such as the transgender and gender diverse people, are especially vulnerable. So for instance, the study from 2010 here showed that more than a quarter of these transgender and gender diverse individuals postponed medical care due to fear of discrimination. Next slide. Next slide, please. Similarly, in the 2015 survey noted that nearly a quarter of the respondents say that they do not want to see a healthcare provider because fear of discrimination, especially among the American Indians and the Middle Easterns. Next slide. So what about in our inland empire? About 0.6% of the population identified as transgender and or gender diverse, and most of them are older than 50 years old. Next slide. The majority of them found it difficult to find a provider for routine care easily. Only 16% of them were able to find a transgender competent provider. Importantly, many of them reported mental health issues. Next slide. So, seeing the need to have culturally competent providers for our community, we organized an educational program for internal medicine residents who see patients in the general medicine clinic at RUHS, and hoping to reduce the care disparity toward transgender and gender diverse individuals. It is titled Crossing the Transgender Care Gap, Building Confidence to Provide Competent and Compassionate Care Through Internal Medicine Resident Education. And it is supported by funding from the American College of Physicians as part of the grants program, Building Trust Through Diversity. Our study team includes Dr. Skuritz and Dr. Huang from the General Medicine Clinic, Dr. Freireich, Dr. Munir, and myself from the endocrinology session, and as well as Dr. Corona and Ms. Lamatripa from to help with the study. Next slide, please. We aim to improve resident physicians' knowledge to barriers to care that the transgender and gender diverse people improve residents' self-perceived competence and competence, and increase their knowledge about transgender care. I'm going to hand it over to Dr. Huang to talk more about the study design. So next slide, please.
Thank you, Dr. Yang. And so our study took the form of an educational intervention study. We had an educational intervention, which was a curriculum that we delivered to our internal medicine residents. And we surveyed the residents both pre and post intervention. We also had a control group of residents who did not participate in the curriculum, but were invited to take both sets of surveys. And we collected information about all of the residents' demographics and baseline characteristics. Next slide. These are a couple slides just showing how our surveys assessed different aspects of the residents' baseline characteristics and knowledge. Next slide, please. This is an example of their knowledge of barriers item that they were asked to complete. Next slide. As well as self-confidence in terms of communicating with transgender patients. Next slide. And then the educational intervention itself consisted of a curriculum with 5 talks in total. The titles of the talks are listed here. We had an extended introduction to transgender care, split between 2 talks, one of which was given by Dr. Ren Massey from the World Professional Association for Transgender Health. We had Dr. Dalia Balsamo with psychiatry present on mental health evaluation for transgender individuals. Dr. Yang presented on medical evaluation and medical therapies for hormone therapy. And then we rounded out the series by discussing preventive health for transgender individuals. The lectures were given live during one of the internal medicine program's didactic sessions with a virtual option so that other residents in our RUHS system could participate in order to increase their flexibility and the participation rate. Next slide. Here are just a few examples of slides presented during these talks. Next slide. And the study began a little less than a year ago. We, after obtaining IRB approval, moved forward with the study beginning in December, and we are closing out now by conducting the post-intervention studies, the surveys. Next slide.
1 minute left.
Yes, thanks. And we were very fortunate to partner with the RUHS Transgender Health Center, including Daisy Mendez, their coordinator, and Dr. Ron Johnson, who oversees the Transgender Health Center. Through the Transgender Health Center and other partners, including IEHP, we were able to deliver staff training to the internal medicine staff on transgender care. And we also were able to increase the number of transgender patients in the internal medicine panel. And we're very happy with the way that the education has been delivered to internal medicine residents whose focus will at least partially be hopefully to practice primary care in the Inland Empire after training. Thank you.
Great, Mommy.
Okay,
What's
thank
that?
you so much. At this time, we're going to go ahead and pass the mic to Deborah Johnson and Curly Palmer, who are program coordinators with Public Health, the Maternal Child Adolescent Health Program.
Hello, good afternoon, everyone. So thank you for that introduction. As stated, my name is Deborah Johnson, and I'm the coordinator for the Black Infant Health Program in Riverside County. And Curly Palmer is going to co-present with me, and she is the coordinator for the Perinatal Equity Initiative program. So I wanted to start off with a question as, did you know that in our county in Riverside, the African American infants are 1 times more likely, they're 1.5 times more likely to be born with low birth weights and nearly twice as likely to die within the first year of birth. And the moms are 4 times more likely to actually go through complications during pregnancy in their birth process. Next slide, please. Next slide, please. Thank you. So to continue that data in Riverside County as well, the prematurity rate for Black infants is 12 versus a rate of 8 for white infants. And the Black infant mortality rate in our county is a little over 7.5 in comparison to 4 for white infants, and this is countywide in our county of Riverside. Next slide, please. So thank you. So with this data in mind, the program has been in existence, the Black Infant Health Program has been in existence over 30 years. And so this was to help address the disparities and the poor birth outcomes that we have had in the African American community. So although we have had some improvements, we still have a long ways to go, as you can see with the data. So I'd like to now talk about the population that we serve. And so we serve women in the Riverside County, and they identify as African.
Oh, we're losing you there, Miss Deborah. So I'll go ahead and jump in here. She looks like she's having some technical difficulties. So for the Black Infant Health Program, specifically, they're serving pregnant African-American moms that live in Riverside County. The state recently upgraded the services so they can now serve moms that are up to 6 months postpartum. They can be 16 years of age now, all the way up to however old they are for birthing. And then finally, like I said, live in Riverside County. So next slide, please. So the services that Black Infant Health offers specifically, there are 20 group sessions that are provided. 10 of those are prenatal, 10 postpartum. They also have the opportunity to have individual life planning with what we call, it's like a life coach. They call them family health advocates. There's also transportation assistance that's provided for the mothers in the program. And finally, there's a case management component. So if the moms are high risk, or if they're, like we mentioned, if they're younger, like 16 years of age, then there's a case manager that's there working with them through the program. There's also the health advocates, like I mentioned. And finally, there is a public health nurse and social worker that works with these moms. The services right now are currently being held virtually because of COVID-19, but prior to that, it's a group centered model. And so that was the way the services were provided. Next slide, please. So recently the state did do some data. They released some of the outcomes as it relates to the Black Infant Health Program. So I think this data was within the last 3 months. And what they found out from the program is that at that time, 51% of the moms, they replied that there was a decrease in smoking within the last month. 45% saw a decrease in food insecurity. There was a 38% increase in the use of yoga, deep breathing, or other meditation strategies. 35% mentioned that there was a decrease in their depressive symptoms. And finally, there was a 33% increase in the intention to put the baby on their backs to sleep. Next slide, please. So I want to move on to the Perinatal Equity Program, the program that I'm the coordinator for. My name is Curly Palmer. And so the Perinatal Equity Initiative really came about because there was a need to expand the services that the Black Infant Health Program are currently providing. What we saw was that there was a need for moms that might not necessarily be able to access the Black Infant Health Program, whether it's because they're working or whatever the reasons were where they couldn't have access. Could you go back just a moment, please? Access to the program. Then we wanted to make sure that we provided the services to those individuals. And so the Perinatal Equity Initiative really is that extra arm for Black infant health to be able to address some of these persistent inequalities that we've seen for a very long time. As Ms. Deborah said, for about 30 years now, we've seen these things happening within the Black population. The other great thing about PEI is that it really is designed to fill in those gaps for the Black Infant Health Program. Next slide. So really quickly, for our county, this program is throughout the state of California, just like Black Infant Health. But for PEI, what we landed upon was 2 different interventions that we had need of for our county. We did this through our community advisory board. We talked to Black infant health moms, and we also had input from other community partners. And we landed upon the community doula services program intervention, and then also our Fatherhood Initiative services intervention. And these 2 are really critical because really quickly, for our doula services within the Black Infant Health Program, many years, many of the moms were saying they wanted to have access to a doula. At that time, having a doula service was an elite service. And so if you didn't have the money, you were not going to be able to have the doula. And so now we're being able to provide a free doula to these moms. They get 3 prenatal visits. labor and delivery, 2 postpartum visits, there's lactation support, and then also other perinatal mental health resources that they may need. And then also we have our Fatherhood Initiative. That initiative was geared towards being able to provide services for African American dads, especially within our county, a population that we know for very long has been really just disenfranchised and disconnected from many of the resources that exist. And so our moms and our CAB members said they wanted to provide services to fathers. And so what we're currently offering now are free 24/7 dads classes. This is a curriculum, this is an evidence-based curriculum. And the goal is to be able to arm these fathers with resources, education, skills to be able to be the best dads they can be. There's also a fatherhood coalition that they have that is meeting monthly. And then there's also connection to other resources.
1 minute.
Thank you, Dr. Leong. Next slide, please. And really quickly, one of the other things we wanted to do was to be able to launch a media campaign that really spelled out the need for others to understand your role and understanding that you have a part in helping moms, helping these Black moms and Black babies to have better health outcomes. And so we launched our Inland Empire media campaign. This is in collaboration with San Bernardino County. All of the things you see listed there are the different areas that we covered within the media campaign. And then finally, there was a video, I can send it at another time, but there's a video that just kind of shows why we need to make sure that we understand we're a part of the village. Next slide, please. And then really quickly, we are having a perinatal equity summit in the fall. And this is really to bring together San Bernardino and Riverside County to talk through and understand what are the perinatal efforts that we have going on within our counties, but then also to bring in families so that they can understand their role and see what it is that we're trying to do as a county, as 2 counties, to be able to make changes. So thank you all so much for your time, and we're really appreciative of this opportunity. Thank you.
Kalisha, you're on mute.
So I'm going to jump in for Kalisha. So next we have Dr. Ron Mccowan, who is our Director of Palliative Care. He's also a trained cardiologist and beloved on our medical staff. Thank you, Dr. McCowan.
Thank you very much, Dr. Leon. Thank you very much for this opportunity to be a part of this elite group here. Such wonderful presentations. I didn't know all the things that were going on in the community that were shared today. So I wanted to share a few words with you about COVID and healthcare disparities. Some of this has been covered already. But I think one of the things that we would all agree with is this huge uptick in the number of deaths during the different seasons, flu seasons, summers, from 2015 all the way to 2020. And I think we all can recall how we felt at the beginning of this pandemic and the preparations that we put ourselves through to try to get ready, and the changes that we saw that occurred with it, and things will never be the same. One of the things we encountered was the fact that curtains were pulled back on this whole idea of disparities. And we got shaken into realities that were in existence at the time and still are. Next slide, please. So data from CDC looks at the race and ethnicity responses to infection, hospitalization, and death. And we look at this first column here. We're actually looking at the cases, hospitalizations, and deaths for American Indians. Number of cases, 1.5 times that compared to the white counterparts. We go to the right, and the Asian group, 0.7, a little bit less. African Americans, 1.1, and Hispanic, that community had 1.5 times the number of cases. In terms of hospitalizations, we had an amazing 3 times increase in the American Indian group. Here again in the Asian community, 0.8, and then almost 2.5 times the white population's number of hospitalizations in the African American community, the Hispanic community, almost 2.5 times as well. The number of deaths, Twice the number of deaths in the American Indian group compared to the whites due to COVID. Here again, 0.8 times in the Asian community, a little more than 1.5 times, and almost twice the number of deaths in the Hispanic community. So the question came about, why are we looking at these sort of differences in the morbidity and mortality related to COVID infections? Next slide. So poverty certainly is one of the major factors. We look at the rates of poverty in the white community, 9%, Black community, about 3 times that, being 21%, the Hispanic community, 17%, Asian, 9.7%. That's a tad more than in the white community. And then in the American Indian and Alaskan Native community, 24%. And as we all know, those are significant factors. Next slide, please. Next slide. Also, there's a disparity in the amount of insurance coverage in the white and Asian communities, very similar, 7.8, 7.2%, and the Black community, 11%. And we get all the way up to the Hispanic community, about 20% do not have insurance coverage. And topping that is the American Indian and Asian Alaskan group. Next slide, please. So this is a slide that we've sort of been talking about with the different presentations. The Mayo Clinic had this publication in Clinical Infectious Diseases in 2021. We look at the COVID infections and the reasons given for the disparities. We start with the environmental factors on the left side. Systemic racism, that's an entire discussion itself, certainly is still in existence. Housing, density, insecurity, pollution, individuals that are frontline or essential workers, that has been mentioned today, and reliance on public transportation. And if we go all the way to the right, look at host factors or individual factors, health literacy certainly is important to helping to promote disparities, socioeconomic disadvantages, language barriers, distrust of the medical system. These are significant factors. And then if we move into the circle here for host factors, chronic diseases, malnutrition, poverty, lack of access to health care insurance, we've talked about that before. And these overlap to form social determinants of health, as been mentioned before. And we have looked at these as social injustices. Now, this is actually a summary of a huge and vast array of topics that certainly, we need to be looking at and continuing to discuss over a period of time. Next slide, please.
1 minute.
Okay. This is a really fantastic study. Let me just summarize it by saying this. This was a European study in which 15,000 patients with 15,000 minority patients were compared to like 392,000 white patients in terms of positivity for COVID, the severity of the disease, and whether or not there was mortality. And they came up with a model that showed if you decrease the depravity by 25%, you could expect at least somewhere between a 40 to 50% decrease in risk for positivity, severe disease, and mortality. So if you could get up to 50% of the disparities reduced, then you get somewhere between 80 to 90%. I think the major part, the take-home point of this is that with small changes, we can expect to see sizable decreases in risk. And so that's encouragement, in fact, I think, to all of us that are doing things here and there, just stay the course. Next slide, please. The big take-home point here, this is a slide showing the depravity and the number of surgical procedures. This was published in JAMA in 2021. They compared the procedures done in whites versus Blacks, and you can see the big gap in the lines here. The disturbing piece is that over time that gap has increased in size. And we have to ask ourselves why. So this is a prompt to us working within the hospital institution to look at our data and to make sure that this sort of thing is not happening. Next slide.
And we're at time.
Okay. All right, this has been talked about before, partnership, that's very important. Last slide. And then solutions. The organizations, we need to look at our data. We need to partner with the community. We need to address implicit bias, which I think that we're making efforts to do that. There's a talk this afternoon about that. Advocacy, that's been talked about, and then quality improvement endeavors. This is by no means a full list of solutions. I mean, there's so much that can be added to this. Thank you so much for your time.
Thank you, Dr. McCowan. Our next speaker is Jana Ariano, who's the Administrative Director for the Inland Empire Health Information Organization.
So hello, thank you guys so much for having me here. And today I'm representing Connect IE, which is a system that links healthcare and social services to address the needs of Riverside and San Bernardino counties. Now, Connect IE is a partnership. As you see here, we do have the 2-on-1s for Riverside and San Bernardino County. This is an IEHP funded project. We do have Desert Healthcare District at the table, along with my organization, which is the Inland Empire Health Information Organization. Next slide, please. So what we do as Connect IE is we are a resource platform. And so it's very easy to go into connectie.org, you place a zip code, you search for a need, and you connect to a community-based organization. Next slide. And once you go into the platform, all of the resources are there in program cards. The one thing that I will point out is that we do have individuals working with the community-based organizations to make sure that all of the information that is in the platform is either daily updated or up to 6 months. Nothing in the platform is anywhere past 6 months as far as being updated and reaching out with the organizations. This is an Aunt Bertha or Find Help powered platform. So they do work with the community-based organizations, and then the 2-on-1s themselves work with the community-based organizations. So all of that to really just say that every resource that is put into this platform across all of the domains at the top are updated within a 6-month time frame. Go ahead and go next slide, please. So when we look at the program cards, like I just mentioned, that it is being managed by the 2-on-1s. A lot of these programs that we put in here throughout COVID, we started looking and there was needs to have 1-day or events. So like distribution of food boxes started going on to the programs. We started reaching out and seeing how can we did some vaccine events through the program cards. So these were things that we expanded on through COVID to put it out into the community. The difference with this particular platform is we do have the community-based organizations, but we also have the healthcare providers. So IEHIO has been working with all of the healthcare providers in our community to utilize and have access to Manifest MedX, or excuse me, to Connect IE in order to be able to provide it to their patients. Next slide. So let's look at the referral process. And one of the reasons that we put this out here is because during COVID, we also started the Food RX program through IEHP, utilizing the Connect IE platform. So we have 28 healthcare providers that have emergency food boxes sitting in their clinics. And so as we look at this referral process, like what does that really mean? Well, you search for the resource. You enter the referral into the platform. A community-based organization receives that referral and they provide that need. And then they also provide the updated information into the platform. So this is considered the closed loop process. So Connect IE has worked really well with our partnerships to make sure that we have a closed loop process that not only is a referral put in, but we don't want the referral to go flat. We basically want to make sure that that follow through happens and that the community members the needs are being met, and everything that gets placed in the platform is addressed. Next slide, please. So let's look at like how we've been utilized. So in just 2021, I pulled up all of the data and there was 155,000 plus searches on the platform itself. And these searches we know we could target like what searches are the most, and it's usually food and housing. We don't really deviate from there. There was one point during COVID that housing became #1, but it's really about even with food and housing being the two things that are searched pretty regularly in Connect IE. You can go next slide. And then for the referrals, In 2021, we had 39,700 referrals placed into the platform alone. And of those referrals, about 33,877, we average about an 80 to 85% close the loop for all of the referrals that are put into the platform. I will say that a lot of this did come from the outreach and one-day food distribution events that happened with IEHP. And the way that it worked was that community members were able to self-refer themselves for a food basket. And the way that they were able to secure that food basket is they put the referral in through themselves into the platform. And then once they went to that food distribution, everything was processed through the Connect IE platform. Next slide, please. So what we're moving into now is, we don't have a lot of data in Connect IE. We get very minimal data when it comes to these referrals. We get like a first and last name and a phone number. Come past June, we are actually moving towards a community information system. So it will have a longitudinal record that is going to expand on the demographics that we obtain from the community members. We are using our 2-on-1 partnership to have community health navigators and community navigators to work with community members to pull in their information as well. And then we have our healthcare partners that we're hoping to expand some of the food part of it, not just be emergency food, but being able to deliver food into the patient's homes is something that we're currently talking about. But the whole point here is that we are going to have a longitudinal record. We are expanding the data here, and we're creating a network that multiple agencies will be able to access this information. So with our healthcare partners, they'll be able to go in, and it is an opt-in process to be able to see which services these patients or these community members are utilizing within Riverside and San Bernardino County. Next
1
slide.
minute.
And so this is the way that we will have the CR, the Community Information System, go. You'll identify the process in an intake form. The client does opt in. They get assessed for need. We are building assessments into the platform with risk scoring, and they will get connected to the resources. There will be a follow-up, and the record will be kept in the CIE network. Next slide. So again, these are multiple agency and access from cross organizations. It's coordinated care between healthcare and community-based organizations, and Connect IE has been a system to be able to link them completely. Next slide. Again, this is just real fast. The partnership, we could not do this without this partnership, having 2-on-1, Desert Valley Healthcare District and IEHIO working to be able to bridge these organizations together is really how we've been able to move the needle with this work that's been done through Connect IE. And of course, IEHP. Next slide. And that is it. Please reach out to me. We are expanding this as we go out. We do have marketing materials that we could provide to you, to the community members, as well as to your patients. That way they can look up the information. We provide the training. And if it's a community-based organization, we'll get you connected with 2-on-1s as well. And next slide. And thank you so very much for this time.
Thank you, Jana. So we are running a little bit behind, and we're going to be a little bit more aggressive with time, so we apologize in advance. Our next speaker is Dr. Shenling Tsang. She serves as our Deputy Public Health Officer, as well as our Quality Medical Director. So welcome, Dr. Tsang.
Thank you, Dr. Liang. I'm excited to be here to talk about this topic. So I'm not an expert on climate change, but as a healthcare provider and a public health practitioner, I thought it was an important topic to highlight the importance of climate on health and equity. So you can see there's been over 200 medical journals published that climate change is the greatest threat to global public health, and urge world leaders to reduce heat trapping emissions to avoid catastrophic harm to health that will be impossible to reverse. So in April of this year, the Intergovernmental Agency on Climate Change released their latest report, which summarized the latest scientific research on climate impacts, adaptation, and vulnerabilities, and efforts to mitigate climate change. And it stated that, and I quote, "The cumulative scientific evidence is unequivocal. Climate change is a threat to human well-being and planetary health." Planetary health, our whole planet. "Any further delay in concerted anticipatory global action on adaptation on adaptation and mitigation will miss a brief and rapidly closing window of opportunity to secure a livable and sustainable future for all. So that was a very, powerful sentence there. And so in May, our governor Newsom, presented a $300 billion blueprint paving the California way forward, and it allocated $47.1 billion towards climate commitment, which is an increase of $32 billion this year to tackle pollution, build climate resilient water supplies, reduce the risk of catastrophic wildfires, and ensure grid reliability and accelerate clean energy solutions, and to protect communities from extreme heat. So you've probably seen the news recently. India and Pakistan have been undergoing unprecedented heat waves, and this relentless heat with temperatures above 100 degrees for days has killed at least 90 people and has led to flooding from glacial melting in the Himalayas, has contributed to power shortages, has stunted India's wheat crop, which is fueling an already emerging global food crisis that we're having. So this heat wave has disproportionately impacted the poor due to lack of generators, lack of access to electricity, which in turn creates a lack of access to cooling. So this graphic is from our California Department of Public Health's Climate Change and Health Equity team. It shows the impact of climate change on human health is significant. So climate change can impact our access to basic human needs such as clean air, water, food, shelter, and safety. Climate change related health impacts can include things like increased number of heat related illness and death, more air pollution related exacerbations on cardiovascular and respiratory diseases, increased injury and loss of life due to severe storms and flooding and fire, an increased occurrence of vector-borne and waterborne diseases, and stress and mental trauma from loss of livelihood, property loss, and displacement. So the next slide you'll see is looking at climate change as the third CD in the epidemiological transition. So public health textbooks define epidemiological transitions as part of the burden of disease. And we saw communicable diseases initially, and then chronic disease has since overtaken communicable diseases over the last century, which is still true even with COVID, because cardiovascular and cancer are still outpacing COVID. Which is hard to, with 1 million COVID deaths, it's really amazing. So with new climate disease, which is, overtaking chronic and communicable diseases, it includes a magnification of communicable diseases, though, like vector, food, water, fungal, and other communicable diseases, as well as a magnification of chronic diseases. So climate change affects everyone. So since communities and individuals experience individuals experience worse health impacts than others. And so people with existing health conditions, people inadequately housed, people who work outdoors, like our farm workers at the bottom there that Luz and her team are working with, our communities of color, our immigrants, our very young or elderly, our pregnant people, and our people with disability, low income, socially isolated people tend to face disproportionate harm from climate impacts. And so if you think about this, these are the patients we serve here at RUHS. So doctors have put a price tag on the annual health impacts of climate change. It's at $820 billion. We're seeing that the healthcare costs are adding up in premature deaths, in need for more medical care, which in turn increases prescription medications, lost wages and worker productivity, and then downstream health consequences, such as delayed care or homelessness. So climate action can result in significant health cost savings, and the actions we take can either positively impact or negatively impact the population for generations. So we're going to do a quick look at a case study on how racist housing policies have created microclimate change within a city that has left neighborhoods sweltering. So with the next slide, with the next slide, you'll see a 1923 city map of Richmond, Virginia, where you can see redlining. And then you'll see that formerly redlined areas have less tree coverage today, and that redline neighborhoods have more paved surfaces. And I apologize, Dr. Kumar, if you could progress in the slides. And that adds to higher summer temperatures compared to city averages. So here in Riverside County, if you keep moving forward, we'll turn our attention locally. So this was taken from Healthy Places Index website, where It looks at the relationship between 23 identified key drivers of health. And you can see that Riverside County is projected to have 154 days above 90 degrees by mid-century. So what that means is that we'll have more ED-related heat illnesses here in Riverside County. And if you go to the next slide, if you overlay HPI with heat, you also see that we're already at low ranking for HPI, as you heard earlier from Kim Saratari, but we're also low ranking for park acres and tree canopy. And in fact, we're the lowest 2% for tree canopy in the state. And that will really impact our vulnerable populations. So the next slide, it's not all doom and gloom. We can take some action. So I'm going to take 30 seconds just to go over the last items that we can do. And if you can just go through the slides. Health and energy, efficiency and affordable housing play a huge role. So how we build our communities intentionally with equity in mind will make a difference, where kids have a safe place to play, affordable housing and food, healthy built environments that make it easier for us to stay healthy, including walkable and bikeable communities, clean airspace, urban and community greening to keep cities cool, and then where people know and care for each other. And so with that, I'll end. Thank you to our DEI team for allowing me the opportunity to present today on climate and its impacts on health.